Assalamu alaikum everyone. In valvular heart disease, today we are going to talk about mitral stenosis. It is incomplete opening or narrowing of the mitral valve. Now come to its causes. Rheumatic heart disease is one of the most common cause of mitral stenosis. The other rare causes involves mitral valve calcification and congenital mitral stenosis. Few words about the pathogenesis of mitral stenosis. First of all, when there is a streptococcal infection in the body, especially the pharyngeal infection, then antibodies are formed against the streptococcal antigen. Then immune mediated damage occur in the valves, especially the mitral valve, which leads to fibrosis and calcification of the valve, and then fusion of cusp of the valves with the subvalvular apparatus or the subvalvular part occurs, ultimately ends up with the narrowing or stenosis of the mitral valve. Because of the stenosis or narrowing of the mitral valve, left atrial pressure rises very the left atrial pressure becomes very high, and due to this high pressure, the hypertrophy and ultimately dilation of the left atrium occurs, and due to hypertrophy and ultimately dilation, there is increased pressure in the pulmonary vessels. Due to increased pressure in the pulmonary vessels, the pulmonary congestion occurs because of the backward flow of blood, and in acute cases, the pulmonary edema develops. Due to pulmonary high pressure in the pulmonary vessels, the pulmonary hypertension occurs in very severe cases, and due to severe persistent pulmonary hypertension, the features of right ventricular failure occurs, and then it leads to right ventricular hypertrophy, and then ultimately ends up with the right heart failure. And then there is a backward flow of blood from right ventricle into the right atrium, that is regurgitation occurs because of the right ventricular failure. And because of very high pressure and dilation of the left atrium, the features of afibrillation occurs, atrial fibrillation occurs in these patients. And due to this atrial fibrillation, the patient has very high risk of thromboembolism because of this atrial fibrillation. Normal diameter is 5 centimeter square of this opening of the mitral valve, and patients become symptomatic when this diameter is below 2 centimeter square, and the severe symptoms appears when the diameter reduces below 1 centimeter square. Now come to its clinical features. First of all, symptoms. The breathlessness is the common presentation. This breathlessness is because of the pulmonary congestion and pulmonary edema, that shortness of breath occurs in these patients. The next feature is fatigue. As we have discussed previously, that due to stenosis, the filling of the left ventricle during diastolic phase will not occur properly, and there is reduced amount of blood in during the diastolic phase within the ventricle. Due to this reason, there is reduced cardiac output, and due to this reduced cardiac output, the fatigue occurs in these patients. This is the most common symptom or the most common clinical presentation in these patients. The other features are edema or ascites, that is fluid accumulation within the peritoneal cavity. This is because of the right heart failure. These two are the features of right heart failure in very advanced stages because of the pulmonary hypertension, which ends up with the right heart failure. It occurs in these patients. And palpitations are because of atrial fibrillation, and atrial fibrillation occurs because of the dilation of the left atrium. Hemoptysis is because of pulmonary congestion, as well as we have discussed previously, because of atrial fibrillation, the patient are more prone to develop the thrombi and emboli. So because of pulmonary thromboembolism, hemoptysis occurs in these patients, and the cough is because of features of left-sided heart failure. And the patient may develop the chest pain because of the pulmonary hypertension, and thromboembolism is because of the atrial fibrillation. Now come to its clinical sign. Atrial fibrillation is because of left atrial enlargement, which causes the defect in the conducting system of the heart, and which leads to atrial fibrillation, that the firing activity or the electrical activity is so severe that physical or mechanical activity will not occur properly, that is less motile chamber of the heart, and which leads to thrombus and ultimately ends up with the emboli formation. The other clinical signs are mitral facies. This mitral facies, that is due to constriction of the blood vessels and due to reduced cardiac output, the cheeks of the patients are dusky pink color because of decreased cardiac output. This is called mitral facies. Now come to the auscultation. On auscultation there is loud S1. This S1 is because of closure of mitral valve and tricuspid valve. This loud S1 is because of forceful contraction of the mitral valve. As we know that it is stenosed in this case, so suppose this is S1. This S1 is very loud because of the forceful closure of the mitral valve because of high pressure in the left atrium. And after S1 there is a systolic phase. This is systolic phase, and after systolic phase this is S2 due to closure of the aortic and pulmonary valve. And then diastolic phase occurs. So this is the diastolic phase. In these patients, this is the diastolic phase, and in these patients the mid diastolic murmur occurs, that in the mid of diastole there is a murmur, which is abnormal heart sound in the mid of the diastole, because normally during the diastolic phase or during the filling phase there is a filling of the ventricle occurs, and there is a opening of mitral valve during the relaxation phase or during the diastolic phase. But in these patients, due to narrow or the incompletely opened mitral valve, there is mid diastolic murmur in these patients. And this is there is opening snap, that is high pitched diastolic sound at the start of diastole. The more the opening snap is closer to S2, the more severe the mitral stenosis. So these are the important features on auscultation. Now come to the other features, that is crepitations or crackling sounds or the basis of lungs can be auscultated by stethoscope because of the pulmonary congestion or pulmonary edema, and pulmonary edema because of left sided heart failure, pleural effusion. So all these features are because of the pulmonary congestion, that is features of the left sided heart failure. And right ventricular heave can be appreciated. This right ventricular heave is because of pulmonary hypertension and loud P2. This P2 is basically the part of or the component of S2. Because of pulmonary hypertension, there is loud P2. So these all are the sign and symptoms of mitral stenosis. Now come to the investigation. The non-specific investigation includes ECG. ECG shows the right ventricular hypertrophy because of the pulmonary hypertension, which is appreciated by tall R waves from V1 to lead V1 to V3 lead. And there is P mitral. This P mitral can be appreciated on ECG by biphasic P waves. Like this, there is a notch between two P waves. So two P waves can be seen. And also there are the features of atrial fibrillation, which is basically a sawtooth pattern on the ECG. Chest X-ray shows left atrial enlargement because of very high pressure because of stenosis, and pulmonary congestion features on the chest X-ray. Echocardiogram shows thick immobile cusps or the thick immobile valve of the heart, and reduced valve area, reduced diastolic filling, and enlarged left atrium. The Doppler echocardiogram is the gold standard investigation or investigation of choice, which is used to check the pressure gradient across the valve and pulmonary artery pressure, left ventricular function. Remember, this is the gold standard investigation or investigation of choice in mitral stenosis. The other alternative investigation is cardiac catheterization. When the mitral stenosis is associated with coronary artery disease, then cardiac catheterization is done. And also it is used to check the mitral stenosis or mitral regurgitation, and also pulmonary artery pressure. So these are the investigations for. Now come to the last but not least, the management of mitral stenosis, which includes the medical management in asymptomatic individuals, and in symptomatic individuals the surgical options are there. So the medical management includes warfarin. This warfarin is used or given to the patient to reduce the risk of thromboembolism because of atrial fibrillation, and beta blockers or calcium channel blockers like nifedipine, amlodipine, etc. So these are given to the patient to reduce the heart rate because of atrial fibrillation, and it due to these beta blockers also improves the filling phase, that is improves the diastolic phase because these relaxes the heart muscles. So improves the filling phase of the heart and ultimately improves the cardiac output in these patients. And diuretics are given to the patient for the pulmonary edema, and antibiotics are advised to the patient as a prophylactic agents to as a prophylactic agents for the infective endocarditis risk in these patients. Because of very high pressure in the left atrium, they are more prone to develop the infective endocarditis, so antibiotics should be given to these patients. The other options in severe cases includes balloon valvuloplasty, and through the catheter balloon is passed, and balloon is then inflated and deflated, through which the valve is opened. So this is balloon valvuloplasty. This is the treatment of choice in these patients. And the indications for balloon valvuloplasty are when there are significant symptoms and isolated mitral stenosis but no regurgitation, and mobile non-calcified valve, and there is no thrombus in the left atrium. So these are the indications for balloon valvuloplasty. And the next option is valve replacement. It is indicated when there is mitral stenosis along with mitral regurgitation and calcified thick immobile wall, and there is thrombi formation within the left atrium. So this was all about the mitral stenosis. Thank you so much for watching this video.